Welcome to our podcast, Cardio-oncology. This is your host, Pratik Doshi, and I'm currently serve as the editor of the JACC Edge monthly newsletter, where we do a deep dive into hot topics in cardiology. We're lucky to be joined today by Dr. Anju Nohria. She's the director of the Cardio-oncology program at Dana-Farber and Brigham and Women's Cancer Center. She completed internal medicine training at Yale, followed by cardiology fellowship and heart failure fellowship at Brigham. It's so great to have you on the show.
Thank you for having me.
So, we do this with every guest, and we're lucky to be here in Atlanta, so I can do this in person. But is there something that you can share for our audience that you enjoy doing outside of medicine?
So I'm really into the performing arts. I used to be big into theater when I was in high school and college, but like most of you, unfortunately, medicine takes up so much time that we all come in multi-talented but remain unifaceted by the end of it.
That's true. And, it's great that we still try to maintain some semblance of our lives outside of medicine as best we can. So to kind of jump into it, cardio-oncology. It's exploded in growth over the last couple of years. There's an entire JACC subspecialty journal dedicated to it with an editorial board and podcasts and everything. But for the general cardiologist or for the general internal medicine doctor, what does cardio-oncology look like practically on a day-to-day basis, either clinically or on a research end?
So I think clinically it's a very large and growing field. I mean, to be completely honest, it's sort of general cardiology, but with a focus on oncology. So as you know, there is a huge growth in the number of oncology drugs that are out there. They're changing on a daily basis. And as oncologic treatment becomes more pathway driven, where they're looking at ways to inhibit molecular pathways that promote tumor growth, many of those pathways are shared by cardiovascular systems, and therefore there's disruption of cardiac growth and proliferation as well. And that is what leads to an increasing number of cardiovascular complications from these cancer drugs. And really what cardio-oncology is knowing the nuances of these cancer therapies, knowing the side effects that they could have, and then taking care of them in a targeted way. You also have a slightly different emphasis where the priority is to allow the patient to continue their cancer therapy without interruption while maintaining or preventing significant adverse cardiovascular events. So really the goal is not so much with a cardiovascular focus as much as with an oncologic focus. So you almost play like the supporting role in the play rather than being the main actor.
Yeah. This is a personal question, but I struggle pronouncing the oncologic drug names. Do you feel like you've gotten better at it throughout your time as a cardio-oncologist?
I have.
That's great.
It is something that where practice makes perfect, right? So the more you say these complicated names, the better off you become.
Okay, I'm glad to know that there's hope in the future for me.
I think so.
So how does one set off on this career path? It sounds like this was a field that was maybe burgeoning or developing when you were in training, but and it kind of has become what it is today.
Yeah, so I sort of lucked into it. As you may or may not know, I'm a trained heart failure and transplant cardiologist, and I got into this field when trastuzumab came into play. So as more and more women were getting trastuzumab, they were developing cardiomyopathy as a consequence of trastuzumab treatment. And at that point in time, Dr. Larry Shulman, who used to be the clinical head of the Dana-Farber, now he's at Penn, approached my chief saying that he wanted a cardiologist who was interested in looking after these women who were receiving anthracyclines and trastuzumab. And my chief asked me if I would be interested in doing that, primarily because I was one of the two women in our group. And I said yes, and that's how I got engaged. So I really got engaged in it more as a subset within heart failure. And then the field took off and became much more, and I grew with it. So I would say that I didn't make a deliberate decision to go into cardio-oncology. I started early enough that I grew with the field.
Absolutely. Well, sometimes these things happen right place, right time, but I think the field overall is grateful that they selected you for this role.
Oh, thank you.
So can you tell us a little bit about maybe some of the current work that you're doing, either research-wise or clinically, and how the two kind of maybe influence each other?
So I think clinically, we take care of three broad populations of patients. So one are the people who have comorbid cardiovascular disease that may become a hindrance to certain cancer therapies or may get exacerbated by cancer therapy, and we take care of those patients. The second big category are the patients who develop cardiotoxicity from cancer treatment, who may or may not have had cardiovascular disease to begin with. And the third is a growing population of survivors, people who may have received cancer therapy in the past that either left them with a long-lasting cardiovascular disability or who are at risk for a cardiovascular complication late after their cancer treatment has been completed. And really our day-to-day work is to take care of all three categories of these patients. From a research perspective, this is a very young field, and actually a lot of the data in the field is retrospective. There isn't a lot of prospective data. There also are very few randomized clinical trials, and those are now growing and becoming more prevalent in this area. I would not say that I am one of the big prospective researchers. I think of myself more as a clinician than a researcher. However, we all do research because that's what makes clinical work interesting, because it motivates your research. So I have been doing a lot of retrospective studies in this area, and I'm participating in several multi-center trials that are looking at specific therapies for cardiovascular complications of cancer therapy. So one of the areas, for instance, is looking at other treatments for immune checkpoint inhibitor myocarditis. So this is the Atrium trial that is looking at abatacept, which is a CTLA-4 agonist that is used quite commonly in rheumatologic diseases as an antidote for ICI myocarditis. And we are one of the centers participating in that. We are also participating in a longitudinal study that is looking to see whether long-term immune checkpoint inhibitor therapy promotes atherosclerosis in patients by causing some low level of inflammation chronically. We're going to be embarking on a study that is looking to see whether people who have heart failure with mid-range EF that is asymptomatic in the context of trastuzumab or anthracyclines need to continue lifelong GDMT, or can they be withdrawn from that safely? So there's a lot of new areas that, and these are just a few of the studies that we're participating in. So I think, for people out there, you don't have to be the one that starts the study. You can also be the one that just contributes patients to these studies.
Absolutely. So for maybe the general cardiologist or the cardiology fellow, what do you wish in your position that they understood about cardio-oncology, or maybe when it's time to refer to a cardio-oncologist?
So I think whenever you're a general cardiologist, if you really don't understand what the drug that the patient is getting can do, I think it's good to contact someone who does know about that or read up on it. There's actually a lot of literature now on these drugs. There are specific nuances for drug-drug interactions or treatment options, even for common problems, things like AFib, MI, etc. I think the one thing I would say is that there's two tendencies, right? One is to either ignore the cancer drug and just look at it from a cardiovascular perspective. The other is to only look at the cancer drug and think that the cancer drug must be the problem and forget about general cardiovascular causes, right? And I would say that have balance in both of those, so you should look into the drug, but you should also think about common causes of common cardiovascular problems in the cancer patient. I think the other thing that people should be wary of is that you do have to think about their cancer journey when you recommend therapy. So for instance, if a cancer patient comes in with an acute MI and you send them to the cath lab, yes, the best thing is to put them, give them a stent, do dual antiplatelet therapy, but you have to think, is there someone who might be more prone to bleeding? Do they have thrombocytopenia? Might they require more biopsies down the road, So can I truncate that duration of dual antiplatelet therapy? What else can I do to kind of make it so that they get the best cardiovascular treatment while still keeping the cancer considerations in effect? So I would say those are the two big things that people need to be aware of.
Yeah, absolutely. With growing rates of cancer and with obviously, an increase in the number of therapies that we have available to us, I see that this is really a field that maybe all of us need to better understand, so that way we can provide appropriate care for our patients.
Exactly, and I think the intersection of cancer and heart disease is only continuing to grow as our population ages, because they're both diseases of the elderly and often they coexist together.
Yeah, Dr. Bonnie Kai, who runs the JACC Cardio-Oncology subspecialty journal, she mentions that cancer patients are also sometimes at higher risks of cardiovascular disease. And so, again, I love what you said, that not everything is because of the cancer therapy, that sometimes cardiovascular issues still occur in patients who may have cancer. Yeah. So I think that's a great point where, it allows us to maintain an understanding of what we have of what's been going on with patients. So for people who are interested in entering cardio-oncology, what advice or resources can you share about people who want to just learn more about this field?
So I think there are lots of avenues where you can learn about it. There is the International Cardio-Oncology Society, or ICOS. They hold weekly webinars on topics related to cardio-oncology. I think that's a very good area, and they're also recorded, so you can watch them after the fact. There is JACC Cardio-oncology, which comes out on a quarterly basis, so it's not like you have a ton of reading to do, but that's a great resource. The ACC holds an annual CME conference that deals with topics of cardio-oncology, which is a great resource. Places like Memorial Sloan Kettering and MD Anderson also hold annual conferences. So those are good places to go to get like a primer in this area in a short time. So I think there's a lot of resources out there, and they're only growing. So that's probably the best way to learn about the field.
Absolutely. I have one more question from our associate editor, Dr. Sneha Nandy, as well.
Thank you so much for joining us. My question was along the lines of Pratik's previous question. For our general cardiology fellows who are interested in cardio-oncology, would you say having training in advanced imaging like cardiac MRI be something that's helpful, or would you recommend they maybe pursue specialty clinics in their particular area of interest in order to further explore either cardio-oncology or another niche within general cardiology?
So I would say that cardio-oncology is sort of a niche of general cardiology, right? I personally believe that it does help if you have another area of subspecialty expertise when you do cardio-oncology. The two areas that I think are most helpful are imaging or heart failure. Just because a lot of the complications that you see fall into those two buckets, in some sense. So I always recommend to people who come to me saying they're interested in cardio-oncology that they either think about doing imaging or heart failure and then do cardio-oncology on top of that. The field of cardio-oncology is not board certified yet, but there are subspecialty fellowship programs that are offered by many centers. Like we have a extra year, of a cardio-oncology fellowship, which is partly clinical, partly research-based. Penn has one, Memorial Sloan Kettering has one. So there are a lot of places that do offer these fellowship programs, and if it's something that you're really interested in, I don't think it's a bad year to invest, in that. You don't have to do it. You can also do it just by attending clinic, maybe, with somebody who does cardio-oncology for a year and learn it that way. But that is a good way. And then the International Cardio-Oncology Society also has a certification exam that they offer. And if you are interested, I would say that that's something worth considering, only because it gives you a certain credential that you need to be able to hang a shingle saying I'm a cardio-oncologist. Or you don't need, but it's nice, right? So I think that. And then I think, in general, how you decide to go into one of these niche subspecialties is often motivated by, if you have an interest in general internal medicine, but you are also a cardiovascular subspecialist, then all of these intersection subspecialties make sense, and what aspect of general internal medicine you like, whether it's rheum, whether it's obstetrics, whether it's oncology. I think it's meant for people who have sort of that general interest in general medicine. So I would say that if you're not interested in that, then you're better to just stick to the lane of cardiology.
Absolutely.
Yeah.
Dr. Nohria, thank you so much for your time. It's such a pleasure to hear from you and learn about all the work that you're doing in advancing this field. For those who want to learn more about cardio-oncology as well as other hot topics in cardiology, please subscribe to the JACC Edge newsletter. For our listeners, this is your host, Pratik Doshi, and we hope to catch you next time on the JACC Edge podcast. Thank you so much for your time.
Thank you for inviting me.